Hello, my name is Dermot Ryan, a recently retired general practitioner from the United Kingdom with a long-term interest in allergic rhinitis and asthma. Today, as part of the IPCRG Rhinitis Right Care Initiative, myself and Juan Trujillo are bringing a case history to exemplify some of the learnings. This is a case of a moderate to severe allergic rhinitis in an adolescent with asthma. We've already brought to you the desktop helper to help the diagnosis of asthma, and particularly to differentiate between allergic and non-allergic rhinitis. Rhinitis is a highly prevalent problem in all age groups that significantly impairs the lives of people with the condition, including the people they live with. Underdiagnosis and misdiagnosis are very common, which leads to under or inappropriate treatment with a significant economic impact and potential harm to the individual. Most people with rhinitis manage the condition episodically, either with self-management plans or over-the-counter medications. However, they underestimate and neglect their symptoms and often do not bring this to the attention of their general practitioner. However, as this is a common problem and a frequent comorbidity of asthma, affecting the management of other conditions as well, it needs to be recognised and managed properly in primary care. This case history is to accompany our latest desktop helper, which is a practice guide to help to improve the management of rhinitis in the primary care environment. The learning objectives today is, first of all, to recognise when the patient has rhinitis, to recognise when the rhinitis is not controlled, and to recognise when step-up treatment is needed. Of course, if there are any red flags, we would hope to identify those. Red flag signs are signs which may indicate other disease other than simple rhinitis. For example, a unilateral nasal bloody discharge, particularly when there's been no history of trauma, or mucopurulent nasal discharge, or facial pain which persists after a period of a few days. It's important to explain the benefits and limitations of AIT for patients with allergic rhinitis. And we do this by shared decision making, discussing expected timelines, the risks, the benefits, side effects of treatment, taking into account the patient's values and preferences. So let's meet Mira, who's come today for her annual asthma review. She's 15 years of age and it's the month of April. She has had asthma for a number of years. It's been confirmed as an asthma diagnosis, and she has excellent control of her disease on a maintenance and reliever therapy regime, otherwise known as a MART regime. Her current medication is a combination inhaler of inhaled corticosteroid with formoterol, 1 puff twice a day. Salmeterol preparations do not meet the needs of the patient for rapid relief of symptoms when they're using it as a reliever medication, and is not suitable to be included in a MART regime. With regards to Mira, her asthma symptoms are only really triggered by specific exposure, and in particular she notices when her mother is using the vacuum cleaner around the house. In the past, her peak flow variability has been documented, and she has demonstrated an excellent response to her treatment with MART. However, during this consultation, I noticed that Mira was sniffing a lot throughout the consultation, and sometimes brushing her nose, rather like that. This prompted me to ask some targeted questions about her nasal symptoms. Remember, 80% of asthma patients have concurrent rhinitis, of which approximately half are allergic rhinitis. The symptoms are often normalised or dismissed by the patients Mira's had her symptoms of asthma for years, and the nasal aspect of things hasn't been noticed by her. She thinks it's normal. So opportunistic screening, such as when patients come for an annual review, is a very useful time to ask questions about whether rhinitis is present or not. Further questions reveal the hidden burden that Mira is suffering from. She has marked nasal congestion. Her nose is feeling constantly stuffy, with a constantly running nose, consisting of a clear nasal discharge. She also has eye symptoms on questioning, with red, irritable eyes, which she has attributed to long hours of study. It does actually impact upon her daily life. She doesn't sleep very well, which gives her symptoms interfering with concentration. Her perception is that this is normal. She's never had anything different, and she's never sought treatment so far. So the duration of the treatment so far has actually been for a long time, many years, with chronic persistent symptoms, even though they've never been reported or addressed. So how do we quantify the impact that the rhinitis is having upon her? There is a validated visual analog scale which takes account of all the domains of nasal symptomatology. So it ranges from 0, where the symptoms are not at all bothersome, to 10, where they're extremely bothersome and life appears very difficult. It includes the symptoms of nasal symptoms, rhinorrhea, sneezing, obstruction, pruritus, and loss of smell, although loss of smell is more common with chronic rhinosinusitis, and also accounts for her eye symptoms, itchiness, redness, and watery eyes. So, asking Mira to do the score on this, she comes up with an initial VAS of 8.5 out of 10, which is very much on the severe end of things. Scores of 7 typically indicate moderate to severe disease requiring intensive treatment. But baseline measurement is important, against which you can measure improvement when treatment is given, but also linked with a diary helps to indicate when things may be worse, so you might be able to pick up trigger symptoms by using it as well. Referring to the treatment ladder for allergic rhinitis, where might we start Mira with her VAS of 8.5 and no previous treatment? Well, she's clearly got more than mild allergic rhinitis because it interferes with her daily life considerably, and she's a high VAS score. So starting on step 1 would not be appropriate. So thinking about step 2, she clearly has uncontrolled allergic rhinitis, and therefore starting on a combination topical nasal steroid, topical antihistamine treatment would seem to be appropriate, rather than progressing to oral steroids or even considering immunotherapy at this time. So after discussion with Mira and her parents, we decided to start her on a combination treatment and to review her in 2.5 to 3 weeks' time, with her doing her VAS score every day to see whether it's improving, and also to see if we can identify any other triggers which might be making her symptoms worse. When she comes back, we will see what her VAS is and discuss further what we might do if she remains uncontrolled. So the treatment strategy we consider for Mira is a combination nasal spray. The rationale being it's a dual action preparation with rapid relief from the antihistamine in the topical antihistamine and an anti-inflammatory effect, which helps to cope with the symptoms of blocked nose that she suffers with, disturbing her sleep and her quality of life. We also think about what diagnostic investigation may be helpful. So in agreement with her mum and Mira herself, we order a specific IgE test, in particular using a panel of aeroallergens. This helps to identify the causes of allergens to guide long-term treatment. Together we decide to use a VAS chart done daily to track her symptoms on a daily basis, and we decide to see one another again in 2 to 3 weeks' time. So Mira makes an appointment to see me again in just over 2 weeks' time. And happily, she reports that she's feeling much less drowsy. She's in improved concentration at school, and even her teacher has noted. And she feels she has a better quality of life. She's enjoying life more. She feels more alert, and she's able to be more like her old self. Interestingly, her VAS has improved from 8.5 to 5.5. There's a significant improvement, but 5.5 still indicates moderate disease, and the evidence suggests that no further improvement from combination in treatment can be achieved in the VAS after 2 to 3 weeks. There's a ceiling effect for this preparation. So we need to consider something else. So we decide to continue the topical nasal treatment and discuss further the results which have come in. The results of the blood test help very much in identifying the culprits. The specific IgE results from the aeroallergens demonstrate that she's positive to grass pollen, and she's also positive to dust mite. So the clinical correlation of this is that house dust mite is a perennial allergen, is present the whole year round. And this explains the persistent symptoms and also her asthma triggering when her mum uses the vacuum cleaner because it raises dust levels in the atmosphere. The grass pollen sensitization coincides with her seasonal exacerbations, so that needs to be taken into account at all. It's very important to remember that many patients with allergic rhinitis have multiple sensitization, and that those sensitizations may or may not indicate an allergy. We discuss further what might be done given the fact that she's taking the medication correctly, she's taking it twice a day, and it's likely that a treatment ceiling has been achieved at 5.5, which is not indicative of controlled allergic rhinitis, and what we might do next. So the next thing to think about is the potential of allergen immunotherapy, which in many countries is undertaken in the specialist environment. The indication for her referral is continuous severity despite initial treatment and improvement. The goal is consideration of allergen immunotherapy. But why allergen immunotherapy? Most treatments for allergic rhinitis are aimed purely at the symptoms, but allergen immunotherapy is a disease-modifying treatment for allergic rhinitis which addresses the underlying immune response, not just the symptoms. The treatment goes on for 3 years to achieve maximum effect from it, but the benefits last well beyond the 3-year horizon. There is also evidence that AIT may prevent progression to comorbidities such as asthma, although she already has asthma, but importantly may prevent the acquisition of new sensitizations. So I write a referral to my friend Juan Trujillo in his clinic, and he will take over the case history from here.
Thank you, Dermot, and thank you so much for the International Primary Care Respiratory Group for making this type of cases so that we can make it as simple as possible. My name is Dr. Juan Trujillo. I'm a pediatric allergist from Cork University Hospital in Ireland, and let's move on. So let's continue with what happens to Mira. Mira has been with allergic rhinitis, have been with different escalation of treatments, and now her visual analog scale has decreased and it's getting a little bit better, but still not enough. So the next steps that we need to think about is to use an allergen immunotherapy. So allergen immunotherapy is a long-time treatment, especially first publications on 1910. So we're talking about more than 100 years old. And there are two different kinds of allergen immunotherapy right now in the whole world: subcutaneous immunotherapy and sublingual immunotherapy. And depending on your physician, depending on your specialist, your allergist, your pulmonologist, will decide to use one of them. Also, it depends on the tendency of the country and how much they're used to use one of these two medications. Subcutaneous immunotherapy, as compared to sublingual immunotherapy, have positive and other options. So there's no right choice to use allergen immunotherapy. You could choose from one to the other. As you can see in this first slide, there are a comparison of subcutaneous immunotherapy versus sublingual. You could see that in subcutaneous immunotherapy, there are the usually named allergy shots that are administered under your skin, usually here in your arm. And the duration is approximately 3 to 5 years, with weekly to monthly injections for approximately 3 to 4 years. And it has proved to decrease the symptoms of allergic rhinitis in pollen, dust mite, and in pet dander. Sublingual immunotherapy, however, has a different way of route. It's sublingual. It's allergy drops or tablets that are placed under the tongue, is going to start releasing slowly, and has a duration of 3 to 5 years. It is a daily administration and also has evidence-based effectiveness for certain allergies, especially grass pollen, house dust mite, ragweed. You can see that there are many studies that evidence the effectiveness of sublingual immunotherapy, as you can see here, and the majority of them will show not only a reduce in the symptoms and the decrease of the use of medications, but also a prolonged sustainable effect with an improved quality of life. The selection of allergen immunotherapy doesn't start with the allergy tests. It starts, and the relevance of the clinical history is essential. The allergy tests are confirmation of this, and it will help us decide which one is the adequate treatment that we can give to the patient. As you remember, Mir has symptoms that were or perennial, or if you can say persistent, and has triggered when there was a vacuum cleaning and there was a lot of dust here. So when we're doing a skin prick test confirmation, and we can see that there is more positive of house dust mite and also grass pollen, it makes the decision easier. But sometimes it's not that easy, and that's where the clinical history is essential. Let's work around here. She had a house dust mite positive reaction with a large wheal in her skin prick test, primarily allergen-driven symptoms. It correlates with her perennial symptoms as asthma trigger, and the clinical decision plus the skin prick test and the confirmation of bloods with a specific IgE that you can use will give us the key of what we're going to do. In the case of grass pollen, she has a small wheal reaction, but also confirms the sensitization, but less clinical significance. And that is the key for our next decision. Now that we have all the information available with a confirmation that this is house dust mite, we should start thinking about what is the proper immunotherapy for her. And we decided to select sublingual immunotherapy in this case. Why sublingual immunotherapy from our point of view? Because it's convenient home administration, excellent safety profile, has a good amount of adherence in adolescents, and targets the primary allergy that is house dust mite. We have discussions with the patients and the parents about the treatment duration that has to be 3 years, and that it's going to be a gradual improvement and with importance of adherence. The idea of selecting the immunotherapy, and I will repeat again, will be selected between the person and the physician and what is more comfortable or what is more adequate for the patient in every step of the way. Part of the daily process that I have to do in our clinic to start sublingual immunotherapy or any kind of immunotherapy is explaining to the patient and to the parents what is the journey that they are going to have, and that is not going to be a quick fix. It's going to be a short, medium, and long-term solution if possible. So the first couple of weeks, between 1 to 4, we start the doses, and you're not going to see a usual clinical improvement. And it's after the first month to the third month that you start seeing slight improvements that could begin, but you have to maintain the full treatment and the medication continuously, because it's not going to be a quick way of solution for their symptoms. Between month 3 and 6, the patient will start having noticeable symptoms reductions and consider to start having an adjustment in their regular medication. Month 6 to 12, the improvements will increase, and then it is a correct pathway to start saying if they need the treatment or the nasal steroids or the antihistamines or the combined medications as much as they used to need. By year 1 to 3, the process of immunotherapy will help you to have a sustained benefit and complete treatment course for long-term efficacy. After year number 3, there's the post-treatment, and there is evidence that a good amount of these patients, for not saying the majority of them, will have a long-lasting disease modification, reducing the medication needs for a long time. And that is what we are actually looking for in immunotherapy. Even though that we are going to decrease the symptoms in quite a few months, our long-term changes of the disease is what we are actually expecting for these patients. So it has been 6 months since Mira started house dust mite sublingual immunotherapy. Her symptoms has improved from the beginning of 8.5 of visual analog scale to now 2. 76% of the reduction in symptom severity and minimal impact in her daily activities. With that, we have decided to titrate down the combination of aceclastine and fluticasone to nasal fluticasone furoate once a day. And we have demonstrated that there is a disease modification with allergen immunotherapy that reduces the medication burden, and we decided we need to continue with the sublingual immunotherapy to continue this disease modification as much as we can. What can we learn about this case? These are clinical pearls that you always need to remember. First of all, to screen actively. Always assess asthma patients for allergic rhinitis. We usually say that if you don't treat allergic rhinitis in an asthmatic patient, the asthma is not going to get better as much as possible. If you don't treat asthma in an allergic rhinitis patient, the allergic rhinitis is not going to get better also, because this is a combined united airway disease. Don't assume patients will report symptoms. They are so used to the symptoms that they find it like a normal part of their lives, including snoring, including loss of smell, including part of her, in this case, daily lives. Always use validated tools. Visual analog scale provides objective measurements for monitoring and will give us a true way to differentiate between being severe, moderate, or mild. Combination therapy works. Aceclastine fluticasone or other combination medication offers rapid, effective symptoms control, will help you with the adherence of the patient. Test to guide treatment, if we identify the allergen, will be crucial for deciding if this is a good candidate for allergen immunotherapy. Always consider allergen immunotherapy early. Disease-modifying treatment to moderate severe diseases. As early as you can get it in the age, the benefits will be better. But always remember about managing expectations. In this time of our lives, everyone wants to have everything a quick fix, a quick resolution of symptoms, but patients have to understand that gradual improvement will be better and that it takes a little bit of more time than usual, and that will ensure them of adherence, and they will actually start expecting it in a longer pace, and they will be happy with that. This case demonstrates the importance of holistic assessment in asthma management. Our 15-year-old patient suffered unnecessarily with severe allergic rhinitis symptoms that impact her sleep, concentration, and academic performance. Through systemic evaluation, appropriate initial treatment, allergen identification, and timely referral for immunotherapy, we have achieved a remarkable symptoms control and reduced medication burden. Finally, what to take home? Allergic rhinitis is not nonsense. It's a disease that deserves recognition and comprehensive treatment. It's one of the more underappreciated diseases in the world. Allergen immunotherapy offers hope for the patients with moderate severe disease, providing long-term disease modification beyond symptomatic relief. Finally, please don't forget to scan this code, look at our practical guide to improve rhinitis management in primary care. Thank you to the International Primary Care Respiratory Group as always. And as always, thank you to my good friend Dermot Ryan, because we have been working together for a long time and it's excellent to have these kind of discussions. Thank you so much.